And I'm pushing recording. We are now recording. Hi, everybody. This is Steve Simpson. It's April, gosh, I can't even keep track of the dates. It's April 9th. I'm coming to you from Paris, France, which is why we are a little bit concerned about the audio quality and what may happen here. Katie Burenheide is our
This
speaker
ain't
for tonight,
working.
and she's going to be talking about antibiotic stewardship, which, as I said in the email, it appears like it might be the flip side or the antithesis of what we're trying to do with severe sepsis care, but in point of fact, it plays a major role in helping us to prevent sepsis with bugs that can't be treated. Um, as I also said in that email, um, my worst nightmare, one of my worst nightmares in the ICU is having someone who has septic shock or severe sepsis or multiple organ failure who actually has that from an infection that is not sensitive to the antibiotics that we have. So um, antibiotic stewardship becomes very, very important, and this is a focus of Katie's. It's actually a focus of mine as well. I probably am more cautious about it than anyone you might imagine. But what we'll do is let Katie go ahead and talk, and then um, I'm going to turn the screen over to her in just a second, and we will let her talk. And then perhaps we'll have some discussion afterwards, depending on how long the talk runs. So, Katie, I am going to change the presenter back to you. And so you should see a thing on it that says on your screen um, to take the screen back. Yes, you do. And yes, you did. And there it is.
And I'm not seeing my presentation. There it
Uh-oh.
is. Okay.
Okay.
Hi, thank you very much. I hope everybody can hear me okay. I'm Katie Burenheide. I'm the pharmacy clinical manager here at Stormont Vale. And today we're going to talk about antibiotic stewardship, the why and how of developing such a program. Just kind of some fast facts. Antibiotics are a shared resource and are becoming a scarce resource.
We'll see you down there, okay?
The information is found about 30 to 50% of antibiotic use in the hospital is unnecessary or inappropriate. Antibiotic overuse contributes to the growing problem of C. diff and a lot of the unnecessary antibiotic use will decrease antibiotic resistance, Clostridium difficile, and other healthcare costs and outcomes. One thing, too, about antibiotic stewardship is not just the large hospital settings, but also can be implemented in small settings as well. And one of the big reasons why we want to improve antibiotic use is to help prevent medication safety and patient safety issues. And there's a link right there for more information by the CDC. It's called the Get Smart program that has lots of information you may be interested in. There's also a resistance map that kind of shows you all the resistance in the nation. And I'm going to see if I can bring this up really quick. And it's a great index. It gives the national trends, and it looks like as you can see here, urinary tract infections and skin and soft tissue infections for the last 10 years and looks at the resistant rates. But if you look at these little dots, it shows you that, just more information, but we're over about 20% or more resistant. The first one here is UTI resistance, and the last one here is skin and soft tissue. You can also review the data by region, and if you look here in our area, the West North Central, and it's about 20% for skin and soft tissue, and down here it's about 23%. So that's another reason why antibiotic stewardship programs are so important in the area. So what is the antibiotic stewardship program? It is an institutional program that promotes and monitors appropriate selection, dosing routes, and duration of antimicrobial therapy. Their primary goals is to optimize clinical outcomes, minimize unintended consequences of antimicrobial use, based on toxicity, pathogen, and also emergence of resistance. This has been endorsed for several years now by multiple different organizations, nationally and internationally. And if you haven't had a chance to see this, but last September, the President provided a document called the National Strategy for Combating Antibiotic Resistance and Bacteria. The document addresses 5 goals that they would like to see addressed, and I'll talk about in a minute the executive orders. But these are the 5 goals. The first one, slow the development of resistance to bacteria and prevent the spread of resistant infections. 2, strengthen national One Health surveillance efforts to combat resistance. 3, advance development and use of rapid and innovative diagnostic tests for identification characteristics of resistant bacteria. 4, accelerate basic and applied research and development for new antibiotics, other therapeutics, and vaccines. And 5, improve international collaboration capacities for antibiotic resistance, prevention, surveillance, control, and antibiotic research and development. Just last month, they came out with the guidance document with those 5 goals, and it addresses the executive orders, what they'd like to see all different national organizations, the CDC, NIH, the FDA, the veterinary government body, and so forth, to help address antibiotic resistance issues. Also, last fall, they released the survey guidelines for CMS surveys. And if you looked at that survey document worksheet, they are looking at hospital infection control practices, but also about antibiotic stewardship programs, asking the questions, collecting data to see if institutions do have an antibiotic stewardship program available at their institutions and how they obtain that information. From talking to some of our infection control people, staff here that do report some of the data now, they said that sometimes they collect the data and these eventually may become measures on down the road, especially with the President's executive orders that have come down this last year. But if you follow the CMS guidelines or recommendations in the past, some of those are antibiotic stewardship strategies that we have to look at, like the skip measures I know has been no longer has to be collected, but like the pneumonia guidelines and CODI and CLOUDI I mentioned later, those are all antibiotic stewardship guidelines too that would help promote the best use of antibiotic practices. So where do you start with the antibiotic stewardship program? The CDC has put out a really good guideline. I had the internet source provided at the bottom there. That's called the Core Elements of Hospital Antibiotic Stewardship Programs. And it breaks down to the core elements of a stewardship program at a hospital. The first one is leadership commitment. You need to have dedicated human, financial, and technology resources to provide a good program. Accountability. They suggest having 1 or 2 key leaders for the program, so it has ongoing continued efforts to continue a great and excellent antibiotic stewardship program. You need someone with drug expertise, whether that's a pharmacist, an infectious disease physician, or someone who really knows a lot, like infection control, about antibiotics. You need to have an action plan, and they suggest following at least one recommendation, like reviewing antibiotics after 48 hours, or to start small first with the initial treatment and obtain outcomes as well. I'll provide some other suggestions here later on, but they do make that suggestion in the CDC guideline. And tracking resistance and prescribing patterns, reporting that data to hospital staff to continue the efforts and improve antibiotic stewardships. And the big one is education. You can't get enough education out there for all clinicians to help prevent antibiotic resistance, antibiotic appropriateness, and optimal prescribing. Other key support, you need clinicians and department heads that are fully engaged into a program. Infection preventives and hospital epidemiologists are also important. They help us too, like, hey, we have, what can we do to treat different organisms, or like trending, like they have MRSA, or say like a patient has pneumonia in the ICU, what can we do to review our practice, see if we're meeting all those measures. So it's really important that you have infection preventives on your antibiotic stewardship team. Quality improvement staff would be extremely helpful too to have with all the MS guidelines, coding, the different procedures like with sepsis, severe sepsis, septic shock. Lab staff is important, especially if you're looking at rapid diagnostic testing, which is great because there's a lot of new testing available out there and everybody's trying to learn how to interpret this information, where to go with it. Also, develop an antibiogram is extremely helpful too for the organization to see what their antibiotic susceptibilities and resistance rates are. And IT, information technology. I know a lot of different institutions have pretty sophisticated computer systems now, but it's really important to have your IT staff involved with you to help make those protocols, those order changes, how you can identify drug-bug mismatch or other lab values to help you with your antibiotic management. And also nurses. You need to have the support of the nurses to make sure the antibiotics be given appropriately based on whatever indication that is. If they have any questions about the antibiotics as well, they know where to go. And when culture results come back as critical values, what they need to do with those too. There's also a really good checklist the CDC put out with this document for antibiotic stewardship programs. I did not put everything on this checklist example, but as you can see, it's pretty quick and easy that you can go through and see if you do have an existing antibiotic stewardship, maybe some things you can help improve it, or if you need to start an antibiotic stewardship program, what things you may already have that you may not be aware of with antibiotic stewardship programs, and what items that need to be addressed. Again, this is just kind of a snapshot, but some of the other areas besides leadership support, accountability, drug expertise, and policies include pharmacy-driven interventions, diagnosis-specific interventions, process measures, antibiotic use and outcome measures, and reporting resistance. So, again, I'd highly suggest looking at this checklist to help establish, or if you have an established program, review to see how you can improve. There is another checklist out there for antibiotic stewardship the Institute of Healthcare Improvement and the CDC came out with. I'm not going to elaborate on it, but that is another document you can use. It's a little more lengthy and more extensive than the CDC checklist, but it is an option if you'd like to look at that too, to how to improve or start up an antibiotic stewardship program. So if anybody's overwhelmed yet, there's a lot of information out there, but really, like the CDC recommends, is to start with one antibiotic stewardship project at a time. Here's a list of just a few suggestions to start with. One, looking at your antibiogram and compare it from year to year to see what your antibiotic resistance is. This can be done, and the lab looks at this every year and just identify who the other person is going to be, whether it's a nurse or a pharmacist or a physician, to see what the trends are at your institution. If you don't already, you can start looking at antibiotic dosing for appropriateness based on indication, based on organ dysfunction, whether it's renal or hepatic, to make sure those antibiotics are used appropriately, or automatically changing the route from like IV administration antibiotics to oral. All of these too, not just are better for the patient, prevent antibiotic resistance, but also can reduce cost as well for the overall institution. You can also look at your quality measures with your quality measure department. Some of the things they already monitor is pneumonia, CLABSI, CODI, BTE prophylaxis, you name it, but they have the data already. Sometimes when we started this program, we just had a lot of silos, and so once we developed the antibiotic stewardship program, bringing everybody into one committee, it really showed what we're doing at that time and how we can improve in all these different areas. But it's definitely quality measures is a good one, especially like right now the Pneumovax and the Prevnar. Prevnar has new recommendations the last couple of years to make sure patients get appropriate pneumococcal, one or the other. Infection control. They monitor your Clostridium difficile rates. They know if it's hospital or community acquired and can help, and you can trend that information too. that's also one of the markers of an effective antibiotic stewardship program. If you have a really good antibiotic stewardship program, your classroom to facile rates will go down at the institution. And a lot of you probably see this as well. C. diff doesn't occur during the hospital stay a lot of times. People are coming in on it. So we're seeing a lot more C. diff in the community versus in the hospital. But again, that's an effective antibiotic stewardship program within the institution. They haven't really enforced, I looked at all the guidance documents too, how we can improve antibiotic stewardship throughout the ambulatory and clinics is probably coming down the pipeline. If you are an accountable care organization, that is one of the measures they look at between transitions of care between clinic and hospital, and that's something that we'll be looking to in the future too, how we can improve our antibiotic usage in our clinics. Reviewing cultures and sensitivities when they come back in a couple of days. Drug shortages. There's been a lot of drug shortages in our recently with Ansef and vancomycin. With antibiotic stewardship program, you can kind of give guidance documents on how we can provide another drug option for those patients, especially in lieu of drug shortages. And lastly, you can look at your antibiotic expenditures over the year and see where those high dollar antibiotics are, and not just antibiotics, antifungals, antivirals, you name it, which might help you guide to start on a project or two to see how you can reduce expenditures if they're being used appropriately or not. That's the big thing more than expenditures, but you want to make sure they're being used appropriately. Education. When you start antibiotic stewardship program, you really make sure that everybody is educated on whatever project you're doing, why you're doing it, and why. It's important all the way from the nursing staff to infection control, you name it. So just don't make any assumptions. Be sure that everybody is educated on whatever topic you're working on at that current time. And we've been amazed too, because we trend here, like our influenza rates during the season or GI bugs that we're seeing a lot of, how a lot of clinicians want to know, hey, what are the organisms that are occurring at this time at higher prevalence than normal, and they like seeing those graphs and things. So, and it's good to make sure everybody's educated on how to read those and how to interpret it so they understand that data. The CDC has an internet site here down below with a lot of good examples. There's examples of antibiotic stewardship programs in rural facilities, antibiotic stewardship with pharmacist only, with ID only, or another physician only. So there's a lot of good suggestions and success stories that you can review that information to see how you can implement some of the strategies at no matter how big of an institution you are. And the big thing is don't reinvent antibiotic stewardship at your own facility, because there's, again, a lot of good information to help guide you so you don't feel overwhelmed, because it is a lot of information to take in at once. So just kind of give you a touch base on our antibiotic stewardship here at Stormont Vale. We initiated this program August 2010, and these are the goals that we wanted to address here. Improve patient outcomes by improving the quality of antimicrobial prescribing by minimizing unintended consequences of antimicrobial use, prevent emergence of resistance, reduce drug expenditure, and start the program and expand it out to the outpatient setting as appropriate. When you develop an antibiotic stewardship, again, we've kind of talked about this, to make sure you have good representation throughout the hospital. So we had our co-director, who's an infectious disease physician, and an epidemiologist, myself help with this as well, and then all the committee members that we felt that were important to help establish this program. We developed what's called the CARES campaign, which stood for Controlling Antibiotic Utilization, Reducing Resistance, Educating Healthcare Professionals and Patients, and Supporting Quality Care for Our Community. And at the time, we still had paper charts, and so all of our suggestions and recommendations, we made pads of paper. They were green and had Stormontville CARES campaign at the top of it with the information, what CARES stands for, down below. And that was really effective to get the information out there about our antibiotic stewardship program and see what we can do to improve antibiotic utilization up on the floors. At first, we have a documentation program that we assessed all the pharmacist interventions on antibiotic stewardship, which included renal dosing, IV to PO, kinetic monitoring, aminoglycosides, vancomycin, and also antibiotic consults. And we had that information readily available, but we just kind of separate out and kind of track and trend to see how we did on throughout the years. At the time, what we decided to do for our antibiotic stewardship is we did have clinical specialists throughout the hospital. So every 2 weeks, we had a training session for the pharmacists, and they all had a guideline, and they reviewed it, whether it's the pneumonia guideline, community-acquired or hospital, or the catheter UTI, aseptic bacteria, you name it, and reviewed that guideline, and then we reviewed our hospital practices at our facility to see how we could improve our treatment and management, and we comply with evidence-based management guidelines. So we now work really well, especially at the committee meetings, because we have a committee meeting once a month with our designated department heads, and we really identified and tracked and trained a lot of different things since then, and I'll kind of discuss that more later. So we identified 9 different projects, or several different projects, and we had results for 9 months. One was antibiotic utilization in the ER. We noticed that there was a lot of single IV dose of vancomycin and Zosyn, and then patients were sent home on oral therapy. We also looked at the pneumonia guidelines to make sure our antibiotics should be used appropriately. And we also, again, already mentioned, checked our interventions to see how we did with various antibiotic stewardship practice in the pharmacy, vancomycin, IV to PO conversion, and so forth. And what we found is, with the ED physicians, we were able to educate and reduce our single dose of vancomycin, so those patients didn't receive vancomycin single dose prior to discharge, but patients who were getting vancomycin or being transferred up on the floors, that was appropriate. But we did see a reduced amount of one-time dose of vancomycin, and that's something, too, that we always keep track of, just to make sure that we're not using a lot of IV antibiotics in the ER if they're going home on oral. And we did see a significant increase in all of our interventions from the pharmacist, and at that time, too, we developed an automatic vancomycin protocol and gentamicin protocol. So if those are ordered in the hospital, the pharmacist just monitors that while the patient's on antibiotic therapy, and then provide recommendations after that if the patient needs to continue, not based on culture sensitivity. So maybe wonder what happened since 2010 with our antibiotic stewardship program. We always review our committee members to make sure we have active participation. We've always been very fortunate to have very active committee members and want to get more involved in how we can improve things throughout the organization. Some of the things we'd like to do is to have someone from one of the long-term care facilities. I just saw a recent article about long-term care facilities adopting antibiotic stewardship programs to help reduce some of the resistance and Clostridium difficile and other complications in long-term care facilities. So that's something we're looking to. And also an ambulatory clinic physician to see how we can help with antibiotic stewardship practices in our clinics. You may remember we only had like 4 or 5 pharmacists that we trained for antibiotic stewardship. Now we have quite a few to train throughout the whole organization. So it's just been great, too, to kind of help streamline those antibiotic practices to make sure patients get the best benefit out of their antibiotic therapy. A lot of different programs are out there right now to kind of help with antibiotic stewardship management. If you don't have a program like this, it is a lot of manual labor sometimes where you get the culture back within 24, 40 hours. You have to look for it, see if it's a positive, or if the lab calls you and lets you know it's a positive. And then you have to go back and see, is the patient still on antibiotics? Is it appropriate or not? We're an Epic institution, but I know that there's several other software systems out there, like Theradoc, Pharmacy. OneSource has a program, too, called, I believe it's Surveillance. But it really helps you streamline antibiotic therapy even better because it gives you direct notification that there's a drug-bug mismatch, like, hey, this patient has MRSA, they're not on vancomycin coverage, you may need to look at it. So it's not manual, it's more targeted driven, so you know where to look for first. Also includes drug lab and antibiotic indications. You may have noticed on the CMS survey questions, one of them is the antibiotic indications, what that medication is being used for. And that's important because sometimes antibiotic dosing is different based on your indication. So that will help alert too, is like, hey, is this medication being used appropriately based on indication, or if that needs to be a different antibiotic or a different dose. So it does help with antibiotic stewardship management, especially since you can run those reports like you see down the right-hand corner, so you can track and trend your antibiotic usage. Automatic protocols. Vancomycin immunoglycoside is a protocol I mentioned earlier we developed. I know some institutions have. It's been great to kind of help monitor vancomycin, being sure it's used appropriately, patient getting adequate troughs based on the guidelines a couple of years ago. And it's gone really well. We're trying to get a pediatric protocol developed as we speak. Pharmacist de-escalation. In the past, we had a 48-hour review. We changed that to a 72-hour review before we get the drug-bug mismatch with the antibiotic stewardship module from EPIC. And the reason why we selected that from 48 to 72 hours, sometimes those cultures are not back in time for 48 hours, so we're looking at 72-hour review to make sure those patients have appropriate antibiotic therapy. Another program is procalcitonin. Our lab has procalcitonin levels, which in the literature is shown you can use it as de-escalation purposes for antibiotics. And so we recently just reviewed a procalcitonin use, so we found out that Blue Cross and Blue Shield wasn't covering for procalcitonin levels. It's considered experimental. So we reviewed it to make sure it's being used appropriately, and we noticed that with procalcitonin you have to trend it every 46 hours after you did the initial one, at least one more time to see if you're going high or low. So we developed educational tools if you do use procalcitonin to identify a bacterial infection, with whether it's sepsis or something else, to give guidance to the physicians and other staff on how to use procalcitonin levels outside of de-escalation purposes. CMS standards. I know I mentioned this earlier, the SCIP was retired, but we did develop an antibiotic guideline for surgical prophylaxis for the OR, and we reviewed all the pre-printed order sets to make sure they're up to date with those new guidelines that came out in 2013, which became a really good document. And we started using that from the get-go from the clinic. So when the clinics would order the medications, if the patient was going to be scheduled for elective surgery, we were able to get the appropriate antibiotic from the get-go versus waiting until they came here into the OR and then would switch to the antibiotics then. So that's been a really good document that has been developed and be used throughout the organization for different procedures and things. Pneumonia is ongoing, making sure we have appropriate antibiotics based on order sets, protocols, CMS guidelines, you name it. We do review that yearly to make sure that we're in compliance with all guidelines. Lab tests. There is a plethora of new lab tests available, and how to interpret and knowing what to do with the rapid diagnostics is very important. And we have a very good lab representative on our committee, and she's always telling us, hey, this is coming up, this is what we need to do, education, what we need to put in our computer alerts, and then we go back and see what education is needed throughout the organization. The new one that has come up is the GI panel. We just implemented this rapid diagnostic testing in January, about end of January. And so we started seeing some of those GI bugs like norovirus or shigellosis, shigella, salmonella, you name it, and everybody's like, wow, you know, we didn't realize we had some of these. We never had that testing before. We always had C. diff and some other things that are now showing up a lot more, so we've developed guidance documents on how to interpret the GI panel and whether or not to treat it, what antibiotics to treat, or antivirals, if pertinent, based on all the guidelines. So that is our newest one that we have available for rapid diagnostic testing. Vaccine programs, we help educate and make sure that we have appropriate vaccine programs based on all the current literature, both in the clinics and throughout the hospital. The newest one, we're making sure everybody realizes the Pneumovax and Prevnar, when to give which vaccine throughout the clinics and the hospital. We'll work on that since the guidelines came out, but there's still some questions about Prevnar and Pneumovax. And luckily, the companies, insurance companies and third payers are now paying for both vaccines. The Adacel one I put up there in particular, we had a campaign several years ago, and we really encourage, if you have 20 weeks of pregnancy or more, we taught all the OBGYNs our birthplace to make sure that the pregnant mothers get Adacel so the patients don't get pertussis. But we also try to develop a cocooning program to include any of the healthcare or anybody that's involved with the patient's baby's care. They get the Adacel as well. Restricting antibiotics, we noticed that some of our antibiotics we might need to have some restrictions on. So we're fortunate that we have 2 adult infectious disease physicians besides our pediatric infectious disease physician that really said, hey, we really need to have these drugs be approved by ID. So we developed a program where a physician needs to order based on approved indication one of the restricted antibiotics, then they need to review it with the infectious disease physician the next day to make sure it is appropriate. And then pharmacy will review, of course, culture sensitivity 72 hours later to make sure that antibiotic is still appropriate for that patient or not. Education. We always have ongoing education about antibiotic stewardship and practice throughout the year. To various healthcare professionals. We're very fortunate because we have a pharmacy clinical nurse liaison in our department who helps us with provide some of the nursing education, which is kind of unique, but he's done a great job providing that service. And again, we have pharmacy students, residents, physicians, you name it, always educating to see what we need to do to improve our antibiotic stewardship practices. In conclusion, antibiotic stewardship programs help manage antibiotic utilization, prevent resistance and inappropriate use. And having an antibiotic stewardship healthcare team is vital for a successful program. Are there any questions?
This is Lee Tolman in St. Paul. I may have missed it, but do you have ID physicians do chart rounds with your pharmacy?
No, we do not. No, we have pharmacists up on the floors that they review the antibiotic cultures and sensitivities, and they call the physician and provide recommendations. If it's something that we're uncomfortable with, like a really highly resistant organism or something else, or organism like Acinetobacter, one of those more resistant organisms, we'll call that attending physician and just say, hey, we see this is growing out of your culture. Would you like to have an ID consulted on this case? And so that's how we've kind of worked it. I've done it in the past. But if it's like something like this patient has Staph aureus, not otherwise MRSA, then we will call and make suggestions, look at culture sensitivity to that physician, attending physician.
Okay, thank you.
Katie, it's Steve. Oh,
Hi.
I'm sorry. Was someone else about to ask a question? No, maybe not. So everybody on this phone call, as you know, spends a lot of time trying to make sure that when that septic patient walks through the door or when that patient becomes septic on the floor, that they get hit as fast as possible with the most broad spectrum antibiotics imaginable. So how do you square that with antibiotic stewardship? And if I'm broadsiding you with the question, I have an answer prepared anyway, but but I think it's you've probably thought the same thoughts that I have. So I thought I'd give you the opportunity to address that.
Yes, we have a sepsis protocol or guideline that have antibiotic selections based on what is suspected, whether it's intra-abdominal infection or diabetic foot or pneumonia, you name it. There's appropriate antibiotic selection based on all the IDSA guidelines that the committee reviewed and determined those are the best antibiotic selection. We looked at our antibiotic susceptibilities as well. So since we have Epic now, they can pull up that order set, see the antibiotic, and just click, 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 and go on. Or they can call one of the pharmacists that's here. We have a 24/7 ER clinical pharmacist that answers a lot of the questions too at night, if need be, to make sure we got the appropriate antibiotic on board. And then the next day, the clinical pharmacy specialists are here to make sure the antibiotics are appropriate if rapid diagnostic reporting has already resulted out.
Yeah. So the purpose of why Surviving Sepsis Campaign says use broad spectrum antibiotics is twofold. I think one is that it helps to avoid that drug bug mismatch that you're talking about, where you give an antibiotic or even maybe two antibiotics, but you really aren't matching up with the likely organisms. And so that's what you were just addressing there, is that you have based on IDSA recommendations, you have specific but broad spectrum antibiotics chosen for specific circumstances. And that's an important point. In fact, Marin Khalif showed specifically with ventilator-associated pneumonia that it saves lives to start broad spectrum with meropenem and aminoglycoside as compared with, and vancomycin, I should add, as compared with trying to hit the specific highest likelihood organisms by themselves, because of the number of cases where you find things that are missed or only partially covered. So it actually fits hand in hand. And the other thing is that, as you notice, your Surviving Sepsis guidelines propose that blood cultures are obtained before starting IV antibiotics, if at all possible. And I also noted on one of your slides that that's a key important component of an antibiotic stewardship program.
Now, with rapid diagnostic testing, if the antibiotic has to be given, from my understanding, the rapid diagnostic testing will still show the organism.
Right. And did I miss that? Do you guys have, how rapid is your testing right now?
With blood cultures, as soon as they get a gram stain, we get a result within 90 minutes.
Mm-hmm. And are you using DNA testing to identify the organisms now as opposed to the standard lab tests? So you have sensitivities back at the same time you identify the organism?
Unfortunately, the rapid diagnostic testing they have now doesn't address cultures and sensitivities, but that is one the executive president orders. In March 2015, the president addressed in that document. Mm-hmm. But right now, the culture statistics still come back within 48 hours. So we know, hey, we have Pseudomonas on board, make sure that double coverage is there. Or if it's MRSA, making sure that MRSA coverage is there, and so forth. So we kind of know at the get-go if our antibiotic coverage is appropriate.
Right.
A couple hours of administration of it.
Right. Another key point to keep in mind, I think, is this, that my friend Anand Kumar told me, actually he told me this like 3 or 4 years ago, that you're all familiar with Anand Kumar because of his paper that showed that the faster you get antibiotics, broad spectrum antibiotics in septic shock, actually he has 2 separate papers. One showed the faster you get broad spectrum antibiotics in septic shock, the more likely you are to survive. And you've seen that your mortality rate goes up by 7.5% per hour during which you don't receive antibiotics. And then the other thing that he showed in a later paper that was published, if I'm not mistaken, in Chest, is that avoiding the drug bug mismatch, which isn't how he stated it in the paper, but the use of broad spectrum beat out the use of less broad spectrum, um, in that if you didn't have an antibiotic that covers your organism with septic shock, you are much more likely to die. And this seems patently obvious, but it again is reason for broad spectrum antibiotics. Um, but the other thing that Anand taught me is, and now they've got tens of thousands of patients in their septic shock database now, and Anand says, and you can't take this to the bank yet because he still hasn't published it, and I keep bugging him about when he's going to. No pun intended, bugging. But uh, he says that their database indicates that the sweet spot for antibiotic duration, even in patients with septic shock, is about 4 days, which I find fascinating, because we don't have anybody who does antibiotics for only 4 days anywhere that I know of. Minimum I see anywhere is a week, and often people will go 2 weeks, in septic patients. His point is, he makes a point that I make for the house staff all the time, which is that all drugs are poisons, including antibiotics, and if you were intended to have them in you, they'd be in you to begin with. They all have unintended effects, and I think you hit on that too, Katie, but such things as levofloxacin inducing QT prolongation and susceptibility to cardiac arrhythmias, things that people just don't think about, lowered seizure threshold from penicillins and carbapenems. Um, and these are things that do cause complications that are sometimes fatal. And Anand says, just sort of taking a look at their database, that 4 days may be the right amount to give someone antibiotics, and the accompanying idea to that is that antibiotics, remember, are not there to kill off all the bacteria in your system. They're there to lower the burden for your immune system to finish killing off. So it actually kind of logically all makes sense, and I hope he goes ahead and publishes some of this stuff so that it will help our antibiotic stewardship programs. Um, Yeah, it's a difficult thing, and you guys will find it's a difficult thing in your hospital because you are constantly hammering people to get those antibiotics in. And then, if you're me, I'm both the sepsis guy at KU and the uh, the medication use guy from the pharmacy who's yammering at the other side to say stop those antibiotics. So people have a hard time hearing me say both things, but I think the real issue is that you want to use the right antibiotic at the right time for the right reason, and when the reason no longer exists, you want to get rid of your antibiotic. Does that sum up antibiotic stewardship, you think, Katie?
And it's really important too because we review our antibiotic susceptibilities every year. Because when we first started the program, we noticed our Zosyn susceptibility wasn't where we like it to be, and our Zosyn
Mm-hmm.
utilization was really high. So that's when we reviewed a lot of our guidelines. And every year we look at all of our current order sets to make sure the susceptibilities for the antibiotics are being reviewed, to make sure we still have the best susceptibilities that we can for the antibiotic selection we need for pneumonia, CMS, sepsis, you name it. So, well, that's been really good. And also, too, every year, at the end of the year, we try to make a big document, not a big one, but just everything and all of our successes we've had over that year. And we just did that just recently, and we looked at when we started antibiotic stewardship in 2010. It really is impressive, all the successes that you do have in an antibiotic stewardship program with having an antibiotic stewardship team and everybody on board. It's very rewarding because it is challenging with sepsis, any type of protocols you have, just everything you have to go through to get policy and procedure or the steps involved to get something going, to where you want it. So that's really important to be sure to have ongoing data so you can show everybody what happens from year to year. encourage everybody, we are doing a good job. Let's see how we can make it even better.
More questions from anybody? Do other people who are on the line have antibiotic stewardship programs?
Yes.
Yeah, that doesn't surprise me that you said yes, Lee. do you fight? Do you have the same sort of people want black or white, I feel like, with almost every question. Um, do you have difficulties being the sepsis guy and being an antibiotic stewardship guy yourself?
No, because I'm not the antibiotic stewardship guy. We have
Gotcha.
we
Okay.
have two ID docs that share that position, and then in that ID group, there are two leaders, and then there's the ID group that we take an individual from and is scheduled to round with pharmacy every day, Monday through Friday, and they do chart rounds and then leave dear doctor notes.
Yeah.
It's just that my question about that is, how do you know that it's successful?
There's various ways you can track it. When we first started, we just had like a little card or kept tallies because we didn't have Epic system at that. Now we have Epic that has our intervention documentation there where we can accept a recommendation or put the information there, and that's what we track every month now.
You track the number of recommendations?
Correct, yes. Our recommendations for antibiotics, we have broken down to our automatic ones, of course, is vancomycin, aminoglycosides, renal insufficiency dosing, route change, whether it's IV, per tube, or oral. And then also, we look at the antibiotic for de-escalation post 48 hours. And then we do consults as well, antibiotic initiation, what dose for initiation, times we have that information as well in Epic.
Okay.
So, Katie, I think what you're talking about is tracking whether people are actually doing what the recommendations say. So then there's a further definition of success. So which I presume would be, are you showing less resistance on your antibiogram to the bugs that you're concerned about? Yes. Are you having fewer infections with them? Do you guys track those things too?
Yes, we do. We track our C. diff rates, our MRSA rate every month to report how that reported out. We have our vaccine rates reported out. There for a while, our pneumonia, when we first started the program, our pneumonia order set was utilized like 30%. So we have an extensive hospitalist group and developed some guidance for them. And now we're at 100% for the pneumonia, so we're always in compliance with each cap. So we have that data as well. So yeah, there's a lot of different things. If you start an antibiotic stewardship program, I suggest only selecting one thing and getting the process down and what outcomes you're going to measure, because there is a lot of information you can obtain from having antibiotic stewardship with all the various departments with quality, infection control, the lab. The lab sends us reports every month what viruses occurring, if they've had any resistant organisms, our sensitivity with the rapid diagnostic testing. That we do provide at those meetings. So there is a lot of outcomes you can obtain from all the different departments on an effective program, but definitely start with baby steps first.
Absolutely. That's good advice for any kind of quality improvement program, including our sepsis programs, is start with the baby steps and the things where you can get quick successes that get people more enthusiastic about it. I agree with you completely on that. More questions from anybody?
Steve, Lee again, I have a question for you after this is completed.
Okay.
It's a sepsis question.
Okay. So what we'll do, if Katie, do you have more that you want to say?
I'm good. Thank you very
You're
much.
good. All right. Well, thank you for doing that for us.
You're
That's
welcome.
it's like I say, it's a very important thing, and I honestly, it does sometimes keep me up at night, going, "Wow, what are we going to do when all these bugs that keep getting more and more resistant, when the antibiotics don't work anymore?" Because honestly, that takes us right back to 1925, when there was nothing that a person could give another human being to help them get past this infection, and that's not a palatable circumstance. And I'm certain that all or most of you have seen this sort of thing in your hospital, where the patient comes with that pseudomonas that's resistant to absolutely everything, and it's not a pretty sight. It just really isn't. So, Katie, this is really important, and I thank you very much for talking to the collaborative about it. And if that's what we've got, I think what I'll do is probably um, just announce that next month our meeting will be on May 14th. The second Thursday is May 14th, and it's already scheduled to be a noon meeting, so I think we will leave it that way. And I appreciate everyone getting on at noon today. Makes a world of difference to me. I don't think I could have made it till gosh, it would have been 1 a.m. start for this meeting for me if we had tried to do it at the evening time slot. So this really helps. And actually, frankly, I'm rather impressed with this GoToMeeting stuff, that it lets us get this accomplished with me sitting in Paris, and it's just astonishing what you can do with technology, and I'm very happy for that. So what I think I will do now is stop the recording. Um, and anyone who wants, or I don't know, Lee, should we go ahead and record whatever the sepsis question is, or you want to?
Sure, I don't.
Okay, sure. Let's go ahead and record that in case there's some germane
Yeah,
things that people might want to hear again.
the first question is a hospitalist, sepsis leader from one of our other hospitals sent me a NICOM protocol from Kansas, and I'm wondering if it's yours. Um, it's about anyone who's in shock or showing evidence of hypoperfusion, and they
Hmm.
all get a NICOM passive leg raise or fluid bolus and a NICOM measurement before deciding on fluids.
Yes, I was instrumental in developing that. It shouldn't actually. I'm not quite sure what the wording on what they got was,
It says assess
but
fluid responsiveness greater than 10% increase in stroke
right,
volume index / cardiac index with passive leg raise or bolus.
right,
Then it
right.
says,
And my personal favorite way to do that is with a bolus, and I think that's people don't do passive leg raises necessarily correctly most of the time. So that's why I don't necessarily trust those. But yeah, so what that is indicating is that some people, including me at Kansas, have let go of CVP as our guiding instrument uh, for fluids during early goal-directed therapy. Um, and that actually is endorsed in sort of a backhanded way by the Surviving Sepsis campaign and by the upcoming Medicare guidelines,
yeah, I
which
think
allow you to do that.
SSC just changed their or made a revision in their guideline.
Right. Well, and the real revision is coming in 2016, and I'm on the guidelines revision committee, and so we're going to be addressing this now. I will tell you truthfully, probably the guideline itself is not going to change on that issue.
I'm losing you, Steve, in volume.
Oh, I'm sorry. Um, see if this works better. I'll hold the mic up closer to my mouth here. Um, so I'm not certain whether the guideline per se will change from CVP based on the data that's actually available in the literature. And, a guideline has to be very, very careful about what quality of evidence and what type of evidence it uses before you actually change the guideline. There are a whole bunch of us who understand and know that CVP is less useful than we would like for it to be in determining who should get fluids and who shouldn't. So because the CVP is a bad surrogate for left ventricular, well, actually for ventricular end diastolic volume and for stroke volume, we have just adopted the use of the NICOM to monitor stroke volume. Mind you, not stroke volume variability, but stroke volume itself, because the principle that guides what we're doing is this, that if you bolus fluids and the stroke volume goes up, that was a good thing. You're achieving what you want. If you bolus fluids and the stroke volume doesn't go up, then there is no further logical reason for giving fluids, because it means that the one thing that you are trying to change by giving fluids is no longer changing. So there's no point in adding additional fluid to the mix.
You're on top of the Starling curve.
Yeah, exactly. So, and without, I can't say too much because this is an abstract that's been submitted to CHEST, but basically our protocol, what we showed is per patient with severe sepsis, about 3 to 3 liters less fluid in the resuscitation period using NICOM than using CVP or usual care with no effect whatsoever on outcome. So we think it will take a lot more patients to be able to show an effect on outcome because, from trials like the FACT trial and the VAST trial, we know that restricting volume, when and where you can restrict volume, that high volume administration is associated with increased mortality, but it took a whole lot of patients to show that, and our study isn't big enough to see that sort of a mortality effect, but we at least are able to show that we see no detriment to patients, and they get less fluid if we use the NICOM.
So you're starting out with a NICOM measurement before you even give any therapeutic fluid?
Well, I think that depends on how long it takes to get the NICOM there.
Sure.
On our rapid response team, they go to the rapid response with a NICOM, so it really essentially delays nothing about the fluids.
Okay.
We have a NICOM in the ED, so it shouldn't delay anything, and we have them in the ICUs, so it shouldn't delay anything in the ICU. So essentially, there shouldn't be any delays to fluid administration from doing this. We tried this similar concept about 4 years ago using the FlowTrack device on an arterial catheter, and we were unsuccessful doing that because we found we always needed to give the fluid boluses before we could get the art line in and the FlowTrack going. So that wasn't as useful a thing. The NICOM is going to pan out, I think, to be a much more useful tool just because it's so fast.
Okay. The other question, it's not really a question, it's another debate with some hospitals being reticent to give a full 30 cc's per kilo for severe sepsis without hypotension. And it kind of falls in 3 buckets as I see it, is that the guidelines recommend giving 30 cc's per kilo for sepsis-induced hypoperfusion with suspicion of hypovolemia. And that there are 3 qualifiers for that hypoperfusion, being elevated lactate, which could be just an intermediate elevated lactate, oliguria, or hypotension. So that means that you could end up giving 30 cc's per kilo to a non-hypotensive patient who has an intermediately elevated lactate below 4. Is that correct?
Correct. Absolutely.
And if you have normal blood pressure, normal lactate, and you're not oliguric, but you're confused, or you have a 50% rise in your creatinine, which would be the most common, or your platelet count's low, go ahead and give 30 cc's per kilo, or would the guidelines suggest that?
I think that the guidelines on the last go around, and probably again on this go around, are going to be a bit reticent about saying it as a hard and fast rule. But I know for sure that everyone who's on that committee gives 30 cc's per kilo as a start for anyone who has organ underperfusion of any type in severe sepsis.
Okay.
So I think what I'm saying is the difference between what can hard evidence truly support and what do the sepsis thought leaders believe. And what the thought leaders believe is you need that 30 cc's per kilo bolus.
Yeah. Okay. Yeah. Unless you have evidence of euvolemia or
right.
If
you have exactly, if you have clear-cut evidence of euvolemia or some harmful thing, like I, for example, last weekend had a patient who had urinary tract infection, soft blood pressure, elevated lactate, but was in florid pulmonary edema because she also had an ejection fraction of 20% and couldn't handle the increased metabolic demand from her urinary tract infection. And so you're hard put to say in that person who was also a do not intubate patient, okay, let's give 30 mLs per kilo right here, right now. It's going to be hard to take back because she was actually already on BiPAP and 100% oxygen. So there are certain circumstances where you'll back away from that, but honestly, not that many. And the person who just has a history of heart failure, this is what people always want to do in my experience, is they'll say, oh, this patient's got heart failure, we can't give that kind of fluid. To that, I say you are wrong. Most people with heart failure can take it. It better be a pretty tight circumstance if you're not going to give the fluid.
Yeah. And then you can use the NICOM to guide you.
And you can use the NICOM to guide you, which is exactly what we did. And so I did actually give her a 500 ml bolus using the NICOM. She didn't increase her stroke volume, and so I felt comfortable not giving any more. And in fact, once we had antibiotics on board and had several hours under our belt, I felt comfortable diuresing her.
And you put her on dobutamine?
No, I never did put her on dobutamine, frankly. I think she came around quickly enough. I suppose you could have made a case for putting her on dobutamine, but I did not do that.
Okay. Well, that's very helpful. Thank you.
Good. My pleasure.
Hope you're enjoying it.
Guys. Oh, well, yes, we're having a good time. We just flew in overnight last night, so we've just been here for the day. So we're a little bit tired from not sleeping, but we're having a great time.
Don't you have a son or a daughter over there?
No, that was last summer I did. Yeah, both of my sons were in Europe for the summer, but they're both back home in Chicago now, or
okay.
Not home. Home's Kansas City in my books, but they think home is Chicago now. So there you go.
Yeah.
All right, guys. So we're 5-6 minutes over now. And so I'm going to go ahead and stop the recording and say thank you, everybody, for being on. As always, you guys are great. We will see you on May 14th at noon, and hope you all have a great month.